So, hello friends. So, we're coming to the last three myths. So, I've covered up to six myths. So, today I'll be talking on seven, eight, and ninth myth. So, these are very important. So, they're more pertinent to our intensive care sort of a patients. Especially for ICU, these three myths become important. So, the first one is in prone ventilation and paralyzed should be fasted. So, I think most of our intensive care friends who are listening to me would disagree with this that they all will be feeding because most of our ICU community are aware that proning is not a contraindication for feeding, but it is good for other specialties to know that just because someone is prone, it doesn't mean we cannot feed, we have to feed them. So the recommendation is that we have to feed. But one thing we need to bear in mind is if someone is prone, there is increase in the gastric residual volume and there is an increased risk of vomiting. So recommendation 7 is that they have to be fed enterally as soon as possible, like any other ICU patient. So proning is not a contraindication. So is there a evidence for this? So this is a evidence. It comes from an Italian study. So a systematic review nursing issues in enteral nutrition during prone positioning in critical ill patients. So here they took 6 studies and which compared supine and prone position. In fact, in this particular Italian study, the gastric residual volume between supine and prone, there was no difference. And they looked at ventilatory associated pneumonia, length of stay, and mortality. There was no difference between the supine and prone from the nutritional point of view. So, which means to say that prone positioning, there is really no reason to think that there is a problem with gastric residual volume and they have to be fed. How about neuromuscular blockers? So, there is a myth that neuromuscular blocker may act on the soft muscles of the smooth muscles rather of the GI tract and it may affect the motility, but it has clearly shown neuromuscular blockers has no effect on the peristaltic movements of the gastric or the gut peristalsis. And in fact, this was a study by by Japanese group, published in 2019, where they showed patients who were on neuromuscular blockers were enterally fed. There was a trend towards reducing the mortality, reduction in hospital-acquired pneumonia, and reduction in ICU and hospital length of stay. So there is good enough evidence to suggest that there is absolutely no reason why someone who is paralyzed should not be fed, why someone who is prone should not be fed. So there is a reasonable body of evidence to suggest that they should be fed like any other patient. So this is an important myth, I think, which possibly intensivists need a bit of clarity. How about patients who are hemodynamically unstable, who are on vasopressors? Would we feed them? So that's a question. So in my ICU, we feed even in hemodynamically unstable. But how unstable? Because hemodynamic instability is a huge spectrum. So there is a spectrum where there is a cascading need for vasopressors, where vasopressors need keeps increasing. Maybe that is the sort of cohort where you may have to hold on. But otherwise, most of the patients who have been resuscitated and where inotropes have sort of plateaued or coming down, we have to feed these patients. So what does Aspen suggest? So the Aspen 2016 says that enteral nutrition should be withheld if MAP, mean arterial pressure, is less than 50 millimeter and where there is an increasing need for vasopressors. But enteral nutrition should be resumed if MAP is more than 50 millimeter where vasopressors are stabilized. So this is what Aspen suggests. So is there studies to suggest that the outcomes are better if you feed early who are on vasopressors versus late feeding in patients who are on vasopressors? So there are this good study that came in American AJCC where they only took patients with who are on vasopressors and mechanical ventilation to see if there is any difference. So the background is they said in hemodynamically unstable enteral nutrition tolerance may be an issue. And there is always this sort of a contention or the thought there is a risk of bowel ischemia in patients who are hypotensive or hemodynamically unstable. And when you feed them, this may compound the bowel ischemia. And this has been shown in the rat models that bowel ischemia tends to occur in hypotensive patients and feeding can be a problem. And there is a phenomena of steel that has been explained where your gut sort of a hypoperfusion happens. And there is an argument, counter argument saying that your mesenteric circulation tends to improve with the feeding because postprandial mesenteric sort of a circulation tends to improve. So there is this sort of an argument which they call it as a steel phenomena where mesenteric sort of a blood flow can be compromised. So this study was done in 2003 where they took patients who are mechanically ventilated with hemodynamically unstable for at least 2 days who have been on vasopressors. They took this group of patients and they compared with early and late enteral nutrition. And as you see, the severity of the disease was little more in the late. Apache was a little more, and SAPS also was more in the late. But when they look at the ICU mortality, you see that it was more in the patients who were fed late, 28.3% versus 22. This was in hemodynamically unstable patients who were mechanically ventilated. Even hospital mortality also was higher in hemodynamically unstable patients who were fed late, 43.9% versus 33, and they were statistically significant. And they showed that early enteral nutrition showed 34% reduction in the risk of death. This was in hemodynamically unstable patients who were on vasopressors for 2 days and mechanically ventilated. And they did a propensity matched sort of an analysis because, as you saw, that the severity of patients was more in the late group because Apache score was more and SAPS. So they did a propensity matching. Even with that, they found that although ICU mortality, there was no difference between late and early, but hospital mortality was still more in the late group as compared to the early enteral nutrition, which goes on to show there are signals to suggest, even in hemodynamically unstable patients who are on vasopressors, early enteral nutrition seems to have a better outcome as opposed to late enteral nutrition. And this was the Kepler-Main curve. So as you see, the survival was better in the early feeding as opposed to the late feeding. And they did a subgroup analysis and they showed that the beneficial effects of early enteral nutrition was seen even in patients who are on multiple vasopressors. If you see the confidence interval, it was statistically significant. Even patients, if they are on more than one or two vasopressors, early enteral nutrition showed beneficial effect. And it showed beneficial effects even in patients who are on vasopressors for more than 2 days, which means to say, even if they're needing ongoing vasopressors, early enteral nutrition showed benefit in this subgroup analysis. So, and there were other studies they compared. So, early nutrition in ICU patients, this was an Australian study which did not show any difference in outcome. And there's one other study where it showed that it improved mortality. But in these two groups, they did not really look into the differences in hemodynamically stable and unstable. And there are no specific guidelines to suggest whether, delayed enteral nutrition, guidelines favoring delayed enteral nutrition. The hypothesis is, as I mentioned, the oxygen delivery would sort of be compromised in patients who are hemodynamically unstable, and there will be increase in the gut oxygen demand. And the mesenteric blood flow needs to compensate for this oxygen demand and supply sort of a mismatch. And it is suggested that postprandially, after the enteral nutrition, there is increase in the mesenteric blood flow, which may help in matching the oxygen demand and oxygen delivery sort of a mismatch that tends to occur because there is something called postprandial hyperemia that happens, which facilitates or enhances your mesenteric blood flow. And the DO2 oxygen delivery and consumption ratio appears better when they are enterally fed. This is all physiological sort of an hypothesis that they have derived that is possibly one of the reasons which helps in improving the outcome, which possibly prevents the gut translocation of all bacteria also, because the gut sort of a mucosal integrity gets breached when they're fasted in hemodynamically unstable patients much more than someone who is hemodynamically stable. So what is now the understanding is, so this was another study from Japan, which showed that mild to moderate doses, when you feed patients who are on norepinephrine with mild to moderate dose, early enteral nutrition showed reduction in 28-day mortality. So what is mild to moderate? So it has been defined as someone who is needing norepinephrine less than 0.3 micrograms per kg per minute. One should continue feeding and should encourage feeding and try to attain the target calories that you may have determined. So that is our understanding. So overall, when you look into this body of literature, if you look at the Aspen guidelines, less than MAP, less than 50, and they're needing increasing amount of vasopressors, better to avoid feeding, wait for the hemodynamic stability. But MAP is more than 50, your vasopressors are settling in. There are studies to favor that early enteral nutrition, at least the study which I showed you, showed good benefit with early enteral nutrition, even in hemodynamically unstable. And if you look at this Japanese study, mild to moderate doses of vasopressors, which is defined as less than 0.3 micrograms, one should definitely feed. But if vasopressors continue to increase, hold on for some time, attain hemodynamic stability, and start with feeding, because that is shown to improve your mesenteric circulation, reduce your gut translocation, improve the outcomes, is what has been shown. So that is our second myth, I think, which is important for all our intensive care community. So the third myth, which I think some units may follow, enteral nutrition should be held before extubation. So this is, again, I think if you recall the myth that I spoke in the previous video, that someone who is secured endotracheally, so, and even if they go for non-abdominal or non-thoracic surgeries, they could be continue to be fed and they don't need to be fasted overnight. So this particular myth is more so when you're planning extubation the next day. So there is some practice that people may keep the patient fasting overnight. I think this is specifically to address that you don't need to fast pre-extubation also. So the recommendation 9 is feed withholding is not needed even before extubation, because that is something we have adopted. Before extubation, we do the gastric suction and empty the gastric contents before we extubate. We don't tend to fast the patients for extubation, but there are no explicit guidelines to suggest that which is better. But are there any studies? Obviously, we are in the world of evidence based. We need to look whether there's any study to substantiate that we don't need to fast before extubation. So there is this nice study which has come from France, where they continued enteral nutrition until extubation compared with fasting before extubation in patients in the intensive care unit. So this came as late as 2023, where you don't need to fast. They had one group which were not fasted and they continued to feed until extubation. So it was a big study, came very recently in Lancet. 1,130 patients randomized between continued enteral nutrition until extubation, and the second group were they fasted for 6 hours before they extubated. They looked at extubation failure. There was no difference in the extubation failure. They looked at the risk of pneumonia within 14 days. In fact, it was shown to be lower in patients who were continued with enteral nutrition until extubation. And suggestion is before extubation, you could just do a suction of the stomach and then extubate. You don't need to generally fast. So these are some of the three myths which I thought were more prudent and useful for intensivists. So the ones I covered is prone ventilation, muscle paralysis, no need to fast, and before extubation, you don't need to fast. You can continue feeding, and hemodynamically unstable. So once some stability is maintained with some plateauing of vasopressors, or if you want any value, if it is less than 0.3 micrograms per kg of norepinephrine, you should feed, because studies have shown favorable benefit with regards to outcome in these patients as opposed to someone being fasted who are on vasopressors. But if you want to stick to the guidelines, you can stick to Aspen, which says less than 50, and cascading sort of vasopressors, hold on feeds. If it is more than 50 MAP and with a stabilizing vasopressors, you can continue feeding. So thank you, friends. So you can request you all to submit valuable work to a Journal of Acute Care and visit my website to rehear to this lecture. Thank you. Thank you.